Awesome. Well, welcome. Thanks for joining us. I'm Allison, and today we're talking with Michelle Benoit, a pelvic floor physical therapist based outside of Charlotte, North Carolina. And I'm so excited to have her on. Tell us a little bit about what you do.
Yeah, so like you said, I'm a pelvic physical therapist. So I work with women who are pregnant, who have just given birth, really everywhere along that spectrum, and help them out with all sorts of pelvic related issues.
Nice.
So yeah,
it's good.
Really fun.
Yeah, and I reached out to Michelle. I made the Diastasis Recti video on the YouTube channel about 3 years ago, maybe 3.5. And it was just like, I kind of stumbled upon it. I had a friend who was pregnant and was really struggling with a lot of lower back pain and kind of struggling to get her core back postpartum. And she asked for some yoga therapy tools. So I made that video for her, and then it kind of took off. And so now I was kind of looking for more information about it and found you, which I'm so excited about, and realized a lot of the stuff that I had in that original video is a little outdated now too. So
there's been a lot of changes, in the way that we talk about diastasis recti. And there's been a lot more awareness around it.
Right.
So for better or for worse.
Right.
You know?
How are you seeing that change? Like what have you seen?
Yeah, so I see more and more pregnant women and also moms who maybe they had their baby 6 weeks ago, or maybe their youngest is 10 years old, who are still struggling with knowing, is the look of my belly, is this diastasis recti or is it not? I don't know. I've never gone to see someone and I don't really know what to do about it. I'm seeing all this conflicting information and I just really need some help.
Yeah. So tell us a little bit about diastasis recti and the anatomy of it, and what are we looking at here?
Yeah. So when you're really talking about diastasis recti, what it's talking about is a lengthening or an opening in the connective tissue that sits between the two halves of your six-pack abs, your rectus abdominis. So it's it's a greater width between those two muscles.
Yeah.
Is really just the fundamental definition of it.
Yeah. And when I was like reading about this initially, when I made the video, it was all about the gap.
All about the gap.
What's your gap? So what's a typical gap? And also, how's that changing?
Yes. So we'll kind of preface this whole conversation with, there is a lot more that we don't know about diastasis recti than we do know.
Right.
So what is normal? I mean, that's hard to say, right? But generally about a 2 centimeter width between the left and the right sides of the rectus abdominis muscles is kind of what is considered in the normal range, and that's really for people who haven't been pregnant or given birth before. So pregnant women who are postpartum, their kind of resting normal gap is actually a little bit larger, so around 2.5 centimeters.
Okay.
So there is some change there in that postpartum, and remember, postpartum is forever, is like what we like to say. So there is some difference there.
Yeah. And what are you sort of looking at when you test yourself? Like,
sure.
How do you do that?
Yeah. So there's a few ways. You can test yourself just by function, right?
Yeah.
Maybe you have a 2-year-old at home, and so you just lift your little one and you look at kind of how does your abdomen respond to the increased load of lifting that you just did. Yeah. But when we're looking at diastasis recti, we're kind of assessing the connective tissue that goes from the bottom of your sternum to the top of your pubic bone.
Okay.
So there's that entire line of connective tissue there, and we're really using that as like a window into the fascia and the muscles that comprise the core. So if you wanted to know on yourself, you could, again, test it out just by doing something heavy around the house and a little bit more demand on your body. In PT, what we do is some combination of the two. So look at people in standing and see, what does their belly look like at rest? Yeah. What does their belly look like when we ask them to load, lift something, push or pull something, and then also look at them lying down. Right. And so that's kind of the classic, I think, if we look into diastasis, right? That's the classic. You're going to lay down, you're going to kind of put your fingers right in the midline and kind of feel what that tissue is like. You're going to feel, again, the gap.
Right.
Where do you feel the two sides of the muscles? How many fingers can you kind of get in that gap? And then you'll load that gap by doing a little bit of a curl up.
Okay.
So kind of like lift your head and shoulders up.
Yeah.
And then you'll see what happens. What happens to that space? What happens to that tissue? And again, we're getting away from only measuring the gap. So, like I said, some of that research I was talking about, 2 centimeters or so is maybe normal. We're going to consider normal. That kind of got translated to 2 fingers.
Yeah.
And then what started happening is my 2 finger width might be different from your 2 finger width, might be different from, say you have a burlier male PT.
Right.
His 2 finger width when he's assessing you might be different.
Right.
So as far as reliability on solely using the width of the gap to diagnose someone as having diastasis is kind of going by the wayside. We're looking at some other things.
Yeah, and you turned me on to Manira Hundani. Is
Yeah.
that how you say her name?
Yeah.
And she, is a pelvic floor PT in Canada and has done a lot with diastasis recti. I was really blown away reading some of her stuff and looking at more like the elasticity and how your core sort of manages pressure. Yeah. That kind of blew me away.
I know.
Tell me a little bit about that.
Yeah. So when we're looking at the core, let's talk about what does that mean?
Yeah, what does it do?
Right. What is the core?
Why do we need a core?
Because everyone's talking about usually core, you go to like your workout and it's all abs, right? So when we're talking about it in the context of diastasis recti, what we are really talking about is the deep abdominal wall muscle, the transverse abdominis, right? So if we think about our middle here as this canister, we're thinking about kind of the front and really kind of wrapping around the sides of the canister. And that's where that transverse abdominis is. And it really extends from somewhere above the belly button to down towards the pubic bone, low in or deep inside.
Yeah.
So that would be kind of the front of that core. We're considering the pelvic floor. So that those muscles that fill in the bottom of your pelvis, that's also part of the core. And then the diaphragm. So those are really like the deep core muscles that we have to kind of pay attention to when we're talking about diastasis. And so the function of these deep core muscles is to provide a stiff and stable base, the middle of us, so that we can do all the things we do. Right. So that we can walk, or we can push, pull, lift, bend, twist. So if you think about it, if we were really floppy here in the middle, all of those other things would be really hard to do.
Right.
And so that's where especially Manira comes in and talks a lot about building pressure in this canister, having that pressure be controlled to form a stiff base to move from.
Yeah.
So that's what we're looking at as far as diastasis. We want to know, as we start to load our core, as we start to load our body, how well do the connective tissues, how well do they take that pressure, and how well do they tension to provide some stiffness here in the middle? And then the same thing with the muscles.
Right.
So how strong are those muscles to be able to do the same thing, kind of create this nice stiff canister for us to do the rest of what we want to do.
Yeah. And how do we know when it's not doing that? Like, we talk a lot, I've had a lot of people write in the comments about like doming and bulging and even like pelvic floor pressure when they're going to lift. Like, what's happening there?
Right. So we live here on Earth in gravity, right?
Yeah.
So anytime that our body is upright, there is some amount of pressure in the middle of our canister. Again, if we didn't have the pressure there to kind of make us stiff and resist gravity, we would just be flopping all over the place. Right. So what that means is, like, if pressure as you go to lift, say, you may notice, like you said, if you've got some of that weakness, or if you have some thinning of that connective tissue, or your connective tissue doesn't take pressure really well, then what you're going to see is you're going to see that pressure move out. Yeah. Right. And so that's what we kind of consider like doming or coning through that linea alba there in the middle. It's pressure that isn't being very well controlled.
Right.
And other symptoms, like you mentioned, that you may notice, pelvic heaviness, for example. Some women may leak, right? When they cough or they sneeze, or they lift their little one, or they're trying to get back to their fitness class, because those are all activities that increase intra-abdominal pressure. And without that kind of stiffness being developed to counterbalance that pressure, it's going to go somewhere else. Right? So whether that means it's going down through the pelvic floor, and maybe the pelvic floor either isn't responding at like when we need it to, or it's not strong enough to, you may notice that there's heaviness or pressure down there.
Right.
If you cough or sneeze, same thing. And and there's not a lot of stiffness or responsiveness here for kind of a pulling in of the abdominal wall. We may get that pressure pushing down through the pelvic floor and then end up with some leaking.
It's different than a hernia, though.
Yes.
Right? Tell me a little bit about that. I just thought of that.
Yes.
I know I didn't prepare to
you're
ask
absolutely
you that,
right.
but
I was actually thinking about that.
Tell me about that.
So a hernia is where you actually have a rip in the connective tissue.
I see.
So that's kind of what differentiates them. And sometimes you can have connective tissue through the middle here that maybe is so thin and so gapped and widened that it presents even like a hernia, right? So we don't always know. Sometimes you do need to go to the doctor, right, and kind of get that area ultrasounded to figure out what is the tissue integrity. But a rip in the tissue, that's a hernia, and that's where we'll see some of the abdominal contents actually kind of spill outside of the abdominal cavity because there's a hole there.
I see.
There's a tissue defect.
Yeah, so I would imagine that's also where it's important for us to start looking at shifting our language away from the separation or the gap, because that sounds a lot like a hernia, like a rib. When it's actually not. We're really just it's almost like an overstretching. I'm thinking the visual I'm getting is like a balloon that you blow up really, really big, and then it's like a little bit more floppy afterwards, but it could still hold water, it could still hold that. It's not going to leak,
it's not going to leak out, or like a balloon that's been used over and over and over again, right? It's stretched and come back, and it's stretched and come back, and so now like some of the rubber maybe isn't as thick as it was. It's kind of thinned out, but it will still hold air. Right. And that is kind of what we do see often in diastasis, and so you're right with the language. There's comparing maybe 3 years ago, 5 years ago to now, and kind of some of the change, there was a lot of kind of fear-built language, I think, about diastasis recti. If you have it, what you can do or what you should never do, right? What is okay or safe and what is unsafe for you. And so that luckily has been changing quite a bit. And I think, again, with the awareness, realizing that in pregnancy, by around the 35th week, almost 100% of women have diastasis recti. Because how can you not?
That intra-abdominal pressure is pushing forward.
You are building a baby, right? You have a whole human being inside of your body. So if you had this short and kind of taut or tense linea alba there in the middle, where's that baby? Where's that baby going? So that is something to know. And I think from a kind of fear standpoint, again, because we get pregnant women saying, oh, I have diastasis. Of course you do. Of course you do. And it's completely normal, right? And so then in the postpartum period, really, and again, not that there's a ton of magic about the 6 weeks, that 6 week time frame, but there is some just healing that happens biologically in that 6 week time frame. So when we're looking at 100% of women around that 35th week of pregnancy having diastasis, and then we shift over to 4 to 6 week time period, now we're looking at maybe 55% of women. So you're getting just natural healing over time as your body readjusts to now being postpartum, having a baby in there. Organs are kind of resettling themselves and things like that. And then, I get a lot of questions too, okay, how long does that natural healing go on for, right? Where do I know where the line is between if I just keep doing my day-to-day, how will this get better? And so we're looking at 8 weeks for that. The same thing. So that 8-week postpartum. And after that, things seem to kind of plateau off.
Yeah. So when you're talking about that 4 to 6 weeks, you're talking 4 to 6 weeks postpartum.
Yes.
And then that's just for things to kind of naturally level out. And then if we're still struggling, feeling low back pain, like what symptoms should people be looking for?
Yeah.
And then, how long once you're aware that you've got that? Is that where you're talking like maybe 8 weeks or something like that?
Yeah, and that's kind of when you might want to reach out, whether you find a pelvic PT in your area, or, sometimes even some body workers are really skilled in working with women who have diastasis. But in that 4 to 6 week time frame, shoot, I forgot what you asked me.
That's okay. No, that's perfect. 4 to 6 weeks. So that actually leads us though into what we were talking about over there, which is what do we do with belly binding? Because that's also part of it. How do we differentiate between the 4 to 6 weeks when you've got it sort of, your body's healing, and then something sort of off? When do belly binders come into play? Do you use them? Do you not use them? What are your thoughts?
For me, belly binders are a completely individual decision.
Yeah.
I think that they can be useful.
Yeah.
So a lot of times, here's what I hear, I just feel so unstable.
Yeah.
I just feel like everything in my body is just swimming around. You might be someone who would benefit from a little bit of external support during that time of healing. So little bit of external support, right? Not like a waist trainer, not something where we are trying to change our body shape necessarily to get a smaller body, but just something externally to support, again, those all of your internal organs. They kind of moved out of the way for baby, and now they've got to really be put back. So binders in that case.
But not necessarily while you're exercising. Correct. Because if you're exercising, my understanding is it kind of defeats the purpose of getting your natural muscles to engage and really being able to feel it accurately. Because if you have that external pressure, you're not going to feel it accurately. And you used a great example earlier of if you do a knee work, you're not going to use your knee brace while you're working on repairing it.
Exactly.
So that was a great example.
So use it in your day-to-day, but maybe a few times a day where you are trying to regain your connection with your midline here. And, you're kind of trying to play with it in different positions and things like that. That's the time to take it off. Yeah. And it totally is. If you had sprained your knee and you were wearing a knee brace around, you would take that knee brace off while you were going to do your PT rehab exercises. Yeah. You wouldn't do it through.
And I feel like you hit on such an important point, which is we're not doing it to make our body smaller or to contort our body. And that feels like maybe that's why we were so focused on the gap, is we want it to be small or right or correct. And it doesn't allow for the fact that there are tons of different variants on a healthy body. Right. Healthy bodies comes in so many shapes and sizes, and healthy postpartum periods look really different. So what would you tell a mom who's super focused on just getting that flat tummy postpartum, or a smaller body?
I talk about this a lot with my clients, because there's so much that's underneath that. There's so much societal pressure. Right. There's so much social media pressure as far as feeling rewarded by comments like, "You're so tiny, you couldn't have just had a baby. Oh, you bounced right back." Yeah. We've really put a lot of stock in those type of comments. So just kind of do a lot of that. What is underneath that, right? Where are you going to be if your stomach was completely flat? What would that change for you right now? Yeah. So a lot of that, and I just really encourage moms to use the postpartum time frame as the time of healing. Yes. This isn't a time to punish your body, right, by over exercising or by restricting calories to get your body into this idea of what society thinks that we should be looking like. Yeah. So we're in a different season.
Yeah, absolutely.
I mean, pregnancy was a different season, and postpartum is a different season. Yeah. And your body will change. Our bodies can change all the time. Right. And they take a while. I heard this quote too not too long ago about, you can't sprint a marathon. Right. And I think in our very, immediate gratification type of society too, we're all out here trying to sprint marathons.
Yeah.
Not only are we trying to sprint one marathon, but we're trying to sprint a whole bunch of them.
Exactly.
Right? We're trying to change our body, but we're trying to get our 4-week-old to sleep through the night, and we're trying to do all the things that really settle with time.
Right.
And focus on nourishment.
Exactly.
Versus trying to change what your body looks like.
Exactly. Yeah. And like you said earlier when we were talking about this, like if you're not nourishing your body and like really getting those nutrients in and taking care of yourself and eating, you're not going to have the building blocks to actually do the repair work that we're talking about here, which is critical. And so many new moms that I talk to, you're forgetting to eat, you're not really sleeping, your self-care kind of goes out the window, but yet you're wanting to get a certain weight. And it's like, well, if you get that weight or you get to that certain size or that finger distance, are you still are you happy? Are you satisfied? Are you nourished? Are you okay? Or did you reach that point and then you're like frozen? In that point, trying really hard not to change.
And you may get to a number from a weight standpoint, and your body may still look different.
Yeah, exactly.
There's things that we don't have control. We can change a lot. Don't get me wrong. We can make a lot of changes in the aesthetics of our body, but we can't change it. We can't control all of them. Right. And there are times when changing the aesthetics of our body takes a lot away from other parts of our life. Yes. It takes a lot of brain power, and it takes a lot of attention to, maybe it's exercise, or maybe it's, you decide you're going to count macros and that's what you're going to do. And so now there's a lot of time and energy being spent in these things at a time when, you could probably be better nourished doing other things.
Yeah. Yeah, so that kind of feeds into my next question. I've had a lot of people writing in the comments asking okay, I've got my gap where I feel like I want it to be, and I feel comfortable, my core can be loaded and sustained, it can sustain weight, but what about the skin changes? Right. And that seems to be what you're saying, that maybe that's one that you just accept that it's gonna be a little bit different postpartum.
Yeah, and same thing. When you're talking about skin changes, for a lot of people, that if you're looking to change it with exercise, which it may change a little bit with exercise, but that's going to be a long range thing. It usually doesn't change super fast. Yeah. And there are just some genetics, and there's some elastin, collagen kind of a makeup of tissues that you may have that skin. And so now, again, it's kind of like you're left with a decision, and you have to make the best decision for you. And if that skin is really, like you said, you've gotten the function back, you can do everything that you want to do. And so we're not talking necessarily I need surgery to repair my diastasis, to repair that connective tissue, but it's just all the stuff on the outside. You may want to consult with a plastic surgeon about that, because that might be the next step of where you're at, and that's totally fine. That's absolutely, what you should do if that's what you want. Right.
I was reading somewhere today, someone was saying in an interview with another sort of working woman, she was talking about juggling lots of different balls. And it's some are plastic balls and some are glass balls, and you have to know which balls are important to you. And if you drop one, you really don't want to drop the glass balls, right? We don't want to let our own mental well-being or our own nourishment or this, taking care of our kids drop for the sake of being so hyper-focused on our skin or something else. So we have to kind of have that healthy discernment of what's important and what isn't important, knowing that they're all up in the air. They all are important, otherwise we wouldn't be juggling them. But we just have to decide what we can let drop and pick it back up at a different time if we need to.
And when we're talking about another place that this rehabbing diastasis has changed is we're starting to look, the core is the foundation. Yeah. Right? But there are certain components of the core that we weren't really looking at too much before. For example, diaphragm movement. Yeah. Breathing. Yeah. The ability. So if we go back to what we were talking about before, and we're talking about the core's job to create kind of a stiff base, support the spine, support the pelvis, kind of give us this stiff base to start moving from. Part of creating that stiff base is being able to have the diaphragm descend so that it is kind of creating pressure down from the top.
Yeah.
Okay. And there are things that impact that. Pregnancy impacts your ability to take a deep breath.
Yes.
Right?
Yeah.
So when we're in that postpartum period, it may be something where you don't even realize it, but a lot of this feels floppy and like it's just kind of out of control because this diaphragm is never kind of descending far enough into this abdomen to really create some tension there in that connective tissue. We see the same thing for like breastfeeding moms, you know? So if you are spending, really doesn't have to be breastfeeding, but that's a good example. Any mom, we are here all the time. We are flexed forward. We are, you know, we're picking up babies, we're holding them. And so there, you can develop a lot of stiffness through your rib cage or your thoracic spine because there's not as much extension going on. Maybe there's not as much rotation, especially if you're feeling kind of floppy in the middle. You might not even realize it, but you know, your rotation may be kind of limited or diminished. So taking a peek at outside of what does this look like and abdominal wall only, but looking at those other components. So the diaphragm, the ability for that diaphragm to expand, to create some pressure through the midline, and to really have that act as like the stabilizing roof, you know, and again, to be able to do that for the diaphragm to descend down, the rib cage has to be mobile, you know, and the thoracic spine can't also be stuck in flexion. We've got to have some flexibility there. So.
Yeah, and you were doing a great job earlier explaining to me like what a gap up here versus a gap down here versus down here might mean. Like what are we looking at and can you kind of explain that and also how the diaphragm, core, pelvic floor, like how do these things work together?
So we'll start with that. How do they all work together?
What do they do?
So Julie Wiebe is a women's health physical therapist. And she has a lot of great information on how this whole thing works together. And how she likes to describe it is think of the diaphragm and the pelvic floor like a piston that kind of moves together. So we just kind of went over the diaphragm, and on inhalation, like diaphragm's this dome that sits here, and on inhalation what that dome does is it widens and flattens down, so it kind of pushes in to the abdominal cavity, and then its kind of neighbor on the bottom, that pelvic floor, it hangs out like an inverted dome. And so as the diaphragm is pushing down on the top, we've got the pelvic floor at the bottom, and it releases and actually lengthens out a little bit. So that kind of happens on inhalation generally. And then on exhalation, just like a piston, it kind of, these things now have some energy stored in them, and then we exhale and we kind of rebound back. So that's kind of how they work together. And then of course through the front and the sides, same deal, right? If we have the diaphragm pushing in to the abdominal wall, what it kind of does is it expands this out just a little bit. You know, it's kind of like as your lungs fill with air, everything else has to kind of make room for that, and so you get a little bit of expansion in that abdominal wall. So you get just that little bit of stretch, right? And same thing. So we've got a little stretch in the abdominal wall, we've got a little stretch in the pelvic floor, and then we exhale, and those things kind of recoil in and up. So that's kind of their relationship with each other. And then we mentioned just different spots where you may notice that you have diastasis, or you may notice, you know, every time I try to sit up from bed, I kind of get this poof, right? Most commonly, we'll see it around the belly button. Right? Because that's generally where we're stretching the most in pregnancy. So less often we'll see it right up underneath the sternum, but if you do, I don't know, I would probably start to look at the diaphragm, the thoracic spine, and the rib cage. Maybe just as a place to start. You know, and see how it's the diaphragm moving. What is the mobility of the thoracic spine like? What's the mobility of the rib cage like? And just assess it and find, you know, treat whatever you find, right? So if you notice there's a lot of stiffness in the thoracic spine, treat that and see if that changes. Again, most common at the umbilicus. So that can really be anything.
Yeah.
You know, that can be the connection and the coordination of just your brain being able to really get the transverse abdominis to engage and to kind of pull on the connective tissue to tense it up, that linea alba, right? As the TA contracts, it almost pulls like a corset, so it'll kind of tension this tissue here. It may be some weakness in the abdominal obliques or the rectus abdominis, right? So although they're not like the deep core, they are still supporting musculature.
Right.
And a lot of times I test, I'll always test rectus abdominis strength and oblique strength in all of my clients. And more often than not, I see weakness in that rectus abdominis. Same thing. If you think about it, kind of it's origin insertion, so where its connector points, that was kind of messed with in pregnancy, and just it's overstretched a little bit,
right?
You know, and so there are times where now we've got some weakness just because it's kind of been on stretch over a long period of time.
Right.
And pelvic floor.
Yeah. So where do we start? Like, if you have somebody who's struggling with some incontinence and they've also got like sort of some core stuff, like, what do you recommend starting with? And like, do we do pelvic floor first? Do we do diastasis first? Do we do it together?
Yeah. I like to do it together.
Good.
I like to do it together. I think. They all go together.
Yeah.
So I think you and I had talked a little bit before about if we kind of take this in phases.
Yeah.
Like, let's say that you had just had your ACL repaired.
Right.
And now you're in rehab, right? And you're going through, there's a protocol.
Right.
And there are certain steps along the way. There are things that are foundational, and then we build on the foundation. And that's really how I look at even postpartum rehab, whether you're 6 weeks postpartum or you have a 10-year-old as your youngest and you've kind of never done the foundational stuff. So from a foundational standpoint, I like to start with reconnecting. We can't really rehab a part of our body if we don't know how to control it, if we can't really feel it.
Right.
And so connection.
Yeah.
And that starts with breath work.
Yeah.
That starts with slowing down.
Right.
And taking the time to feel, where is your body moving? Maybe where isn't it moving? Are you holding tension?
Yeah.
Right?
Yeah.
How many of us are like walking around these like little stress balls? Tense. Yeah. And so, I call it the connection breath activity, and that's kind of pretty widely known. Like in pelvic PT, we'll instruct people to do this connection breath. Take 5 minutes, maybe 10 minutes, right? That feels like an eternity.
Right.
You really start dialing it down. But take that time and focus on, just pay attention to, where do you feel air moving, or where do you feel your body moving as you inhale? Where do you feel it moving? What do you feel as you exhale that air out? So just like we had talked about, inhalation, you should feel kind of this circumferential expansion in your rib cage. And then it kind of,
Yeah.
right? I like my clients to do it lying down even, because it's not just necessarily lateral, but if you're lying down, you'll notice that your rib cage at your back, that will expand also and kind of push into, right? So on inhalation, circumferential. So it's just an easy way to feel, is my rib cage even moving?
Yeah.
And maybe it's not, and then we know. And then same thing, I'll just have them lay their hands right on their belly. Same thing. Yeah. As you inhale and exhale, do you feel a slight rise and a slight fall in your abdominal wall?
Yeah.
And then what tends to be the most abstract is that little bit of pelvic floor movement there at the bottom.
Yeah.
Right? So with inhalation, we should get this little bit of an expansion.
Yeah.
Most of us are not connected at all to what's going on in our pelvis.
Right.
I wasn't.
Yeah.
I had been a PT for 6-7 years or something like that before I did any pelvic floor training. And I had a C-section, and I still didn't know what I was doing.
Yeah.
And then I went to the class, right? and started learning more of this information. But that's super abstract for most of us because we're like, I don't think anything happens down there. I don't know. I never really paid attention. So, what you can do is you can kind of pay attention to the space between maybe your pubic bone and your tailbone. Maybe you feel that just fills a little bit when you inhale. And then you notice as you exhale, that kind of, that feeling of being full just diminishes just very slightly. Or you may pay attention to your ischial tuberosities, those butt cheek bones, right? And as you inhale, you may notice that they move just a little bit apart. And then you exhale, and they kind of feel like they come back together. So that is really the starting point for whether it's specifically that you are coming in with diastasis, recti, or you are having stress incontinence, being able to feel these components of the core is really step one. Okay. And then from there, what we want to do is we want to start coordinating a contraction, or like an isolated contraction. Again, if we think back to like the ACL thing, okay, first what I need to do, right, is I need to get my brain paying attention to this quad again, because that surgery kind of messed it up. And really, like pregnancy, vaginal birth, or C-section kind of mess up the messenger, you know? So we got to reestablish that. So then once we reestablish it, now we start to say, okay, now I want this quad to work maybe while I'm lying down. But then maybe just while I'm standing up as well, or maybe while I'm sitting. And we do the same thing in the core for diastasis, stress incontinence, anything really. And so we start to say, okay, now we know that the deep core is that transverse abdominis, and we know it kind of pulls like a corset. All right. And so we may start training it along with our breath. On inhalation, just feel our belly fill. On exhalation, maybe we actively say, can I draw this belly in, almost like narrowing kind of our front to back, all right, circumference. And then when I inhale, can I let it go? And I exhale. And can I engage and pull that in, right? And so we're in sitting. And we know that this core is creating this stable base for us in all kinds of positions. So this is where I'll tell my clients, let's get the ability to connect and coordinate this and be able to do the engagement. So for some people, they do great in sitting, but if you get them lying on their back, they're like, I lost it. I can't connect there. Other people do great lying down, but you get them in sitting, and there's almost too much resistance of the kind of abdominal organs on the abdominal wall. So you can find where the person can connect the best. And when we look back on that whole pressure thing, at rest, if you're inside lying, you have like the least amount of pressure. Right? And then supine is a little more prone. You're lying on your stomach. There's going to be pressure down on the abdominal wall. And then we go ahead and sit or stand. And those are kind of the highest, just at rest. So we have people practice in these different positions, figure out where you connect to the easiest, and really train that, right? So that your brain gets really good at doing that. And now we're going to start to ask you to do it in different positions. And really it's the same thing in the pelvic floor as well. So we need some action of the pelvic floor for the same reason that we need the diaphragm, the same reason we need the abdominal wall. These guys work as a canister, and so we need the muscle group on the bottom, we need them kind of doing their part, right? To kind of stiffen the canister at the bottom so that we can do the things that we want to do. And so in the postpartum mom, we'll usually see kind of three camps of people. All right. So some people come in, they're just weak. Muscle weakness, right? And I think that's the typical mom that we think about. Some come in and can't connect. Just I know what you're telling me to do, and I understand it. I just can't do it. And so we work more of that connection stuff. And some come in and they're just kind of really stiff. and their pelvic floors are already kind of sitting contracted. They're like little guards down there. And that's kind of where that connection breath comes in as well, as kind of getting through that. So once we reestablish that, okay, that pelvic floor is now not sitting stiff, and you have a nice connection, then we'll work on coordinating different asks of the pelvic floor. So when we contract the pelvic floor, we can kind of think of that muscle group like this little elevator that moves up and down. Okay, when we contract the pelvic floor, we're kind of taking the elevator up towards the top floor of, you know, maybe a 10-story building, for example. And then we want to let it come back down. And so I'll instruct my clients and we'll play around a little bit with engaging that pelvic floor, kind of contracting it. Can you maybe vary where you take your elevator in that 10-story building, you know, and that's kind of like the intensity of your contraction, right? It's like working at 33 RM versus like a 10 RM, for example, you know? So can we take it just a little bit? Can you ask for a little more? Can you maybe hold it for a couple seconds? Or maybe you can hold it for, right? Or maybe you can hold it for 10 seconds. Yeah. But same thing. So once we get wherever you can connect the best to it, and then we'll put you in different positions.
And is that the same as a Kegel or different than a Kegel?
Yeah,
like
so
what
a
you're talking
Kegel,
about, like the elevator.
Yeah, a Kegel is kind of a generic term for a pelvic floor contraction.
Okay.
So again, there's different, depending on what we want to do. Maybe we just want to strengthen, and we're going to tell you, like, take your elevator up, pull it to the 10th floor out of that 10th floor building, and you're going to hold it there. Yeah. Really a lot of strength training. Or for some people, we're just working on, can you connect it? Can you get it to do different things? Yeah. Because it helps to build your brain to body connection. Right. And it helps to build that variability in. Right. You know, we'll need different action of this core if you go to lift your 6-week-old who weighs, you know, maybe 12 pounds versus you're going to also lift up your 3-year-old who's tantruming on the floor, right? Kicking and screaming and also playing the limp, like between the two, right? So those are different demands. So that's kind of where that little bit of like coordination stuff comes in. Yeah. Asking for, you know, can you connect to these muscles? Can we build some of that motor pattern in different positions, right, under different demands, right? And then we get to the challenge part, which is picking up that 35-pound 3-year-old who is initially tantruming and then is playing the, you know, limp.
So you have this beautiful way of explaining like your approach to diastasis with your 3 C's. So walk us through like those 3 C's, and maybe we do that connection breath that you were kind of talking about, if you can guide us through that.
Yeah. So that's exactly it, right? Starting with the connection is just taking your time, taking your thoughts and your attention, right? Taking our attention and putting it back into our own body. Okay. So what do I feel as I am just sitting here? What do I feel up in my rib cage? And, you know, use your own hands, right? So just kind of stick your hand over on your rib cage and just think, what am I feeling? Does my rib cage move into my hand as I inhale? And then does it kind of just recoil back, right, as I exhale? You know, even kind of just sticking your hand on the back of your ribs here. Oh yeah, I feel that expansion, right? Yeah. And then same thing at the belly. So what are you feeling here? You know, some people may feel more of that rib cage or chest movement, less of the belly movement. This is also where we can kind of go back to even before you were pregnant. Yeah. You know, there are some of us who are ab grippers. Right. We're always gripping in. You know, we're always holding a very certain posture, or, you know, it's been trained in us that you don't want your belly to stick out. Yeah. Some people are glute grippers, so you'll have maybe more tension in the pelvis, for example. So connection breath is also kind of good at identifying those things. Yeah. Maybe you're, you know, super tense up here, so nothing here moves. Right. So, but then you move here. And sitting is a great spot to really just try and, again, feel what's going on down in that pelvis. You know, we have got these nice firm seats underneath us. So as our pelvic floor bulges or stretches a little bit, we're gonna feel that onto this hard surface.
Yeah.
You know, so you're just kind of saying like, okay, I'm gonna really pay attention to my butt cheek bones here. And as I inhale and exhale, do I feel some difference in what it feels like around my ischial tuberosities?
Yeah.
So, and then from there, this is where we can add on the graded or the coordination part.
Yeah.
Where we start to pull in, okay, so as I'm exhaling, now I'm also gonna intentionally kind of engage STA.
Right.
As I'm sitting, I'm going to intentionally tell my pelvic floor, I want you to lift up into the pelvis. And then I inhale and I release that. Okay. So kind of just creating that fluidity too.
Yeah.
I think is really important when we're just getting back to really good function here of the middle.
Good. So connection, and then we're looking at our control and our ability to isolate and control that.
Yep.
And then tell me a little bit, like you mentioned, we sit, we kind of do hands and knees, we can play with lying down, being on our bellies. And so we've got our connection, we've got our control. When do we start challenging it? And when do there's a lot of don'ts. Like when I was learning about diastasis recti, it was like, don't plank, don't crunch, don't do these things. So like, but I noticed that like in the more recent stuff, it's talking about planking and doing planks. So tell me about the challenge part. That's our sort of third C, right?
So so you get the first two C's down, and now you want to start to challenge yourself and, do this, right, ideally with like a PT, or it could be a fitness trainer who has some kind of training, and we want to watch how are you doing whatever. We'll pick plank, for example. So if you get down in plank and you can engage this TA, and we see some kind of reduction maybe of that dome or that cone down the middle. You engage your TA, we see some reduction there. It's easily like we can kind of push that cone and it moves nice and easy, meaning that if we weren't able to really kind of push it or have some reduction there, we might know that this thin connective tissue is really stretched to the max with the abdominal contents on it. If it was really hard, that we might say, you know what, this might be a little bit too much. Let's change the position, for example. So challenge involves a whole bunch of different things. We can play around with how someone might be breathing while they're doing an exercise. We can play around with the variables. So how long might I keep you in that plank?
Yes. Yeah.
When we first start, get down there. Let's have you stay there through 2 breaths. Like, can you keep that TA engaged? Breathe through a couple of breaths and come out of it. Yeah. And that's where you start to, again, change your variables, create your progressive overload. Right. And that is really basic fitness training. Yeah. Progressive. Yeah. The idea of progressive overload, right? Pick a place to start, assess how do you feel in that. If you come out of a plank and you say, actually this whole area is kind of sore, like it does not feel good. Yeah. Then that's not for you right now.
Don't do it.
Right. That's not for you right. Or you are maybe using so much of those like back extensors in that plank to keep you super rigid that you come out of it and you're like, my back was like really sore while I was there. Yeah. Then that's probably not for you right now either. Right. What you could do is you could come up to plank on a bench. Or you could come up to plank on the wall. Right. So we're always just following progressive overload. What can your body handle right now? How does it feel? Pain's always an indication that something's got to be looked at a little bit closer. Right.
Pain, or then with DR, if we're doming or bulging, is that a cue to keep doing the practice, or do you back off at that point?
Yeah. So it kind of depends. It kind of depends. If you can we can kind of play with that bulge a little bit, and it's not so hard. That bulge isn't so hard that we can't really like reproduce it at all or really move it. Then that might tell us that thin connective tissue is kind of stretched to its max.
Yeah.
You know, where it might be on the verge of like overloading.
Right.
If you're, you know, bulging or doming a little bit, but really there's not many other symptoms, you're able to engage your TA pretty well.
Yeah.
You can play with different breath patterns. You know, you can kind of breathe through it, or you're engaging on your exhale. You might be good to go, because there's some bit of overloading that connective tissue that is going to be required to make it change.
Yeah.
You know, because I personally think, this is just opinion, but I personally think that a lot of times we're limiting ourselves in the progress that can be made out of like the fear thing.
Right.
The I should never, I can't ever plank.
Yeah.
You know, my doctor said, you know, that I can't lift more than 10 pounds.
Right.
And when we put that stuff into the context of life,
Right.
so what do you do with your 30-pound, you know, toddler?
Exactly.
What do you do then, right? If you can't lift more than 10 pounds.
Yeah.
So, and this is kind of where we are shifting away from always do this to heal,
Right.
and never do this, to this very much more of a continuum on it depends.
Yeah.
It depends. Are you going to get in your plank and you're going to hold your breath and you're going to grit through it, and you have this big, stiff, you know, dome going on underneath, where you have no TA engagement, you don't really have any control over what pressure you are bringing into your body? Yeah, that's probably not for you.
Right.
Not for you.
Yeah.
Right. But on the other side, if you're in that plank and you can begin with that TA engagement, and you know, maybe there is a little bit of a dome or a cone there through the middle, but you're breathing through it. You're able to maintain that TA brace there, then you're probably okay.
Good. Yeah.
There. Yep.
I was so surprised to learn some of that from reading Munira's stuff. Like, you know, she says if you had been exercising that and doing that, you know, previously, it's doable. You just have to build up to it. And we've got to be able to sort of feel those muscles engaged to make sure we're keeping everything safe.
That's right.
So I love that.
Yeah. And feeling where pressure is in your body, and are you the one controlling the pressure, or is the pressure just, you know, is the pressure, are you gaining the stiffness by breath holding, by staying like really rigid, and you know, are we not utilizing the muscular system for some of that that control?
We've got to have that connect, control, challenge, your 3 C's, which are excellent.
And don't limit on the challenge part. You know,
that's good.
Again, I think that's where a lot of us run into trouble,
Right.
and trying to sprint the marathon.
Exactly. So on that note, like, what would you hope that all of your clients and everyone watching, like globally, and you know, people who even don't have access to a PT, like, because I know a lot of people watching might not have access to physical therapy depending on where they are in the world. Like, what would you want women to know?
There are first of all, there's so many resources.
Yeah.
You know, if you don't have access, we're going to put some info in the notes of, you know, who to follow, who's got great info, because you can find the resources out there to do a lot of this stuff on your own.
On your own, yeah.
For sure.
You can
make huge strides. But other than that, I would love for women to know that we can take the fear out of it.
Yeah.
For sure. Our bodies can change. They change over time, and they change based on what we practice and what demands we put through them.
Yeah.
You know, I will also say again that sometimes that initial work is tedious stuff.
Yeah.
It's like not the fun, sexy stuff.
Yeah.
You know, just sitting and breathing.
Right. That's still so important.
Or, you know, or resting.
Yeah.
You know, initially postpartum. Or making sure that your nutrition is, that you're eating nutritious food.
Right.
Right? You're getting protein as the building blocks, and you're getting tons of vegetables for all the other stuff.
Right.
You know, we're staying hydrated. Just like creating an environment in our body for our body to do the work of building.
Yes.
You know, that is huge. But we can always make changes.
Yeah.
Yeah.
That's so empowering. And knowledge is power. You know, Diastasis Recti, people weren't talking about that 10 years ago, you know, and even the video I put out 3 years ago, that is quickly becoming outdated as we're working on learning and growing and better understanding it. So
right. We didn't have great research, you know, and there are some research warriors out there doing a lot of this research, and just also understanding where we are in really that postpartum spectrum. Yeah. You know, because if you're coming into the kind of heavy exercise type portion of it, and you're just out of the gates at 6 weeks, like your rehab program is going to look a lot different than someone who is, again, like 4 years postpartum. Right. They've been living life. Like ultimately you've been living life, right?
That's a good point.
You've been taking care of your kids. You've been carrying in 10 bags of groceries at a time. You've probably had some colds where you've been coughing and sneezing. Those are all big, you know, increases in pressure and stuff like that. So, you know, to kind of take the fear out of it, like plenty of stuff that we do just day to day in life.
Absolutely.
Stresses the system, you know?
Absolutely. Yeah, I'm always amazed. Like, you know, one of the things I find myself writing over and over in the comments is, you know, listen to your body, pay attention to your body, learn to notice your body, because our bodies are vessels for moving through the world. They do lift our babies. They do move children around. They do pick up groceries and cook and prepare food and work. So, you know, they're powerful bodies, and the only guarantee we get in a human body is it's going to change. You know, if we get lucky enough to get to old age, we are guaranteed wrinkles and a changing body and probably some weight changes, you know, and that's a privilege to get to that point. And so I am always finding myself saying over and over, listen to your body, notice that it's changing, and remember how powerful it is.
And truly, like, okay, so the listen to your body thing, right? There's so, like, what are we listening for, right? So with diastasis, for example, you may be listening for back pain.
Right.
Now, not every single person who has diastasis recti, who has maybe a widened gap or kind of just thin tissue is going to have back pain, but some do. So listen for back pain. Listen and just feel what you feel in your pelvis. Like, do you feel heaviness or pressure after some activity or an exercise class or whatever you're doing? Are you leaking? Like, these are all just little signs that something in this system isn't quite working the way that it should work. You know, and then when you're listening to your body, don't fight with it. Don't tell it like, no, shh. Like, you're not really saying that. I'm just gonna power through it.
Exactly.
Listen to it. You know, kind of take a step back and say, what might this be telling me? And like you said, education. You know, just kind of starting to understand the whole system that is the middle. I mean, you know, anybody, y'all can go and just figure out and kind of learn. There are so many resources on the internet about just muscle systems,
how it works,
how it works, and what things are kind of connected together.
And like listening to your body, it's an action step, right? It's not a passive thing. It's listening and paying attention, and paying attention is an action. And then we do have to rest it sometimes. We do have to back up, and we have to go forward sometimes. We have to listen if we're not feeling, you know, that movement. So, well, this has just been such a pleasure, and I think we're going to probably have some future collaborations too. So that's going to be exciting. And how can people find you?
Sure.
And
I am on both Instagram and Facebook at All Natural Female. So you can find me there, and same website, allnaturalfemale.com.
Awesome. And we're going to put in the sort of comments or like the little blurb under this video some of the resources that we talked about today, some other people who are doing amazing work in diastasis recti and postpartum support. We'll put just some facts like frequently asked questions and some of that. So all of that information will be under the video. But yeah, hopefully you found this really helpful and packed of information. I'm incredibly grateful for you for sharing your time.
Well, I love that you asked me to be here because it was really fun, and this is what I love talking about.
Awesome. Yeah, you're really good at it and such a gift to your clients. So we are very gifted and blessed to be able to have her here talking with us. So Very, very grateful for everyone who's tuned into this video. As always, if it's been helpful for you and if you want to stay tuned in for future videos, please make sure to like and subscribe to the page so you stay up to date. Make sure to follow Michelle to stay up to date on all the things she's doing. She shares a lot of really good stuff about postpartum health and wellness. And yeah, thanks for tuning in.